Okay, so I'll start now. First of all, I want to say how sorry I am that I'm not able to be with all of you at this Sangath conference in Kolkata. It's a topic which is, as many of you know, very close to my heart, and something which I believe very passionately about. My talk today really is not going to have any data in it. It's really very much about the big picture about the use of non-professionals to deliver mental health care. And as you can see in the title of my talk, I'm interested in the use of non-professionals, not just in countries like India and in other low-resource settings, but in fact all around the world. I want to start my presentation just by simply reminding us that perhaps the single most exciting innovation. Can I suggest, Urvita, if you can turn the microphone off at your end? Thank you. The most exciting innovation in the field of mental health care in the last 10 years has really been the demonstration that non-specialized providers can provide a whole range of interventions, and I'll talk a little bit more about that a little later, in community settings. In my mind, this has been the most revolutionary new development in our field, because for far too long, I think many of you will remember, when we would talk about mental health care, automatically, at least at the level of policymakers and the healthcare system, people would automatically assume that we were talking only about mental health professionals. And in a country which has such few mental health professionals, most of whom who work in urban areas, most of whom do not provide anything more than a medication, and most of whom who work in the private sector, that effectively meant that the vast majority of people in India, and indeed, I would say around the world, have not received community-based psychological and social interventions. My own journey in this area really began really when I was inspired by women such as the one on this photograph, whose name is Anjana. As you can see from the courtesy at the bottom, this is one of the community health workers who works with Search, the iconic NGO in Gadchiroli, led by Abhay and Rani Bang. Anjana is basically being trained here to actually weigh a baby. It was when I discovered that women like Anjana, who were essentially women who lived in the village with most of whom had not finished schooling, were being trained by Search to diagnose and treat newborn infections that were killing thousands of babies in that region, that I started wondering whether the same strategy, that is to say, using community-based workers to deliver mental health care, was something that could be a viable one. It was because of this that about now 15 to 20 years ago, I think, I wrote the first edition of my book, Where There Is No Psychiatrist. And even though that book has gone on to be used in many different places, these are just some of the more than 20 translations of that book. The book also became used by the International Red Cross and a number of humanitarian agencies. The truth is that way back in 2000, when I started writing this book, there was no evidence at all in the scientific sense that this approach of using community-based, non-specialist workers to deliver mental health care interventions was not even effective, which is of course a very important question, but there were also questions about safety. Was it safe for these sorts of relatively less trained providers to deliver mental health care interventions? Now, what is the role of science in all of this? And I really want to spend a little bit of time emphasizing how important it is to build science around these sorts of ideological positions. The ideological position, of course, was that mental health is too important to be left to psychiatrists and psychologists alone. But that's still an ideological position. And one has to remember that whenever one has an ideological position such as this, there will be pushback. There are many different groups in our society who will feel threatened, including, of course, mental health professionals themselves, that their turf, their territory is being invaded. And it is only through science that we can demonstrate whether or not this ideology actually has a solid evidence base. To return to the example of Anjana, Abhay Bang used to tell me that, when they started working with women like Anjana in these villages in Gadchiroli more than 25 or 30 years ago, there was great pushback from the pediatrician community. Pediatricians were saying that what the Bangs was doing was downright dangerous. To train women like Anjana to treat newborn babies with pneumonia and sepsis was a dangerous strategy in their mind. The fact that there was no alternative, the fact that thousands of babies were dying of a completely treatable condition because there were no pediatricians in the region, that did not strike the pediatric community, it seems, as being a really major concern. Nevertheless, the pediatricians pushed back, and Rani and Abhay Bang decided that the only way to really test their ideology was to run a scientific experiment, an experiment that we call a randomized control trial. This is a scientific experiment which is the most important or the most highly regarded kind of experiment in medicine and in public health. So they conducted a trial in the villages in Gadchiroli, really examining, comparing villages in which women like Anjana were delivering care for newborn babies with villages where nothing special was being done, just as we might call it, care as usual, which really in those villages was really no care at all. And they published their findings in this landmark paper now 30 years ago, in 20 years ago, in the Lancet Medical Journal. It was one of the most important papers in the history of the Lancet Medical Journal. It showed that through women like Anjana, they were able to reduce the mortality in newborn babies by 40%, a staggering reduction. However, there was still an enormous pushback from the pediatric community. People refused to believe this one study. And so over the next 20 years, with the support of the Indian Council of Medical Research, this particular experiment was replicated in 4 or 5 sites around the country, and indeed now also replicated elsewhere in the world. The result is that finally this approach of using what we now call and take for granted as the ASHA worker has now become part of the National Health Mission. The ASHA worker, already 1 million such workers are deployed in India, and there's a strong chance that this number will be greatly increased, are now delivering this very intervention called home-based newborn care to mothers around the country. For me, this is a really great example of how one can turn ideology into something which is adopted and scaled up through the public system, through the avenue of science. Using a scientific approach, the Bangs were able to demonstrate that the use of community health workers was not only effective, but also very safe and acceptable to the mothers in their communities. And through replicating this model scientifically in a number of different sites, they were able to show this was not only a very unusual or specific example from their work, but actually represented something that could be generalized, that could be applied across many different contexts, many different settings around the country. And then it became part of the national health policy. This is precisely what my colleagues and I in Sangath and in many parts of the world have been experimenting with for the last 15 to 20 years. Amongst the earliest such studies came from Uganda, where in 2003, a team were able to show that lay people in villages could deliver a psychological therapy for depression in the villages of southern Uganda with great effect. Some years later, my colleague who has worked with Sangath very closely, Atif Rahman from Pakistan, was able to show that lady health visitors, who are the equivalent of the ASHA worker in Pakistan, were using cognitive behavior therapy very effectively to treat postnatal depression, depression occurring after the birth of a baby. And then in Goa itself, we ran what is still the largest ever experiment in global mental health, in which lay people were trained to provide care for depression and anxiety in primary healthcare settings in routine primary healthcare clinics across the state of Goa. Since then, Sangath has also been extending its work to a number of other mental health conditions, such as this work that was done with people with chronic schizophrenia. This was done actually in several sites in India, not just in Goa, but also in Tamil Nadu, as well as in Satara, in partnership with other NGOs, SCARF and Parivartan. We also ran the first program ever in India to examine how community health workers could support the families of people who have been affected by dementia. This particular experiment actually won an international prize from the Alzheimer's Disease International Organization as one of the most important innovations in psychosocial management of dementia in that year. And we have subsequently extended this model now to a range of other areas. I haven't included the work that Abhijit and his team have been doing in alcohol use and substance use related conditions, because I'm sure he has shared that with you separately. But here you can see examples of how we've extended the same approach for such a diverse range of conditions and contexts. Autism, maternal depression, although the maternal depression example here is interesting because it was done both in India and Pakistan simultaneously, as was the autism example, in fact. But what is also interesting in the maternal depression example is that the delivery agent is another mother in the community, not a community health worker even, but just another mother living in the same community or village as the mother who has depression. Seher is very interesting. We ran this program in Bihar. Here the lay counselor was working not to treat necessarily adolescents, although that was part of their role, but it was mostly to work with adolescents in these schools in Bihar to transform the environment of the schools, to make them feel much more agents of change in their school. And we're delighted that this particular experiment not only had very big effects on depression, but also on violence and a number of other important school health outcomes. And then the final example is the first example of prevention in this area. This is from Goa, and this was a study in which we evaluated how lay people could use a problem-solving based counseling approach for the prevention of at-risk older people in primary care. What I'm really excited about right now is about a program that we're leading in Delhi and Goa, in which we are experimenting now with the same approach to create a completely comprehensive school mental health program, which has 3 steps. At the base step, every classroom gets a sensitization intervention, which includes a wonderful 2-minute video, which hopefully my colleagues might be able to show you if there is an opportunity during the conference. Those adolescents who feel they need to see a counselor then go and refer themselves and see a counselor, which is available in the Delhi schools. But in Goa, we are experimenting with a new app that we are designing for delivery on a smartphone. And those who still remain unwell in spite of receiving this intervention can see a psychologist who then delivers a psychological therapy. The reason why we have this step 1 is because as many of you will know, most mental health problems in adolescents tend to be quite transient. And the goal really for these adolescents is to get them to recover quickly, but equally to be able to identify early on those adolescents who are likely to have a more protracted or serious problem and step them up. So this is a very good example of a public health approach to addressing mental health problems in a closed system. And the closed system here is the school. But what we're also very excited about is that our work with adolescents in schools is also part of a much larger initiative called It's Okay to Talk, which is trying to engage young people across the country into a conversation about mental health, primarily through encouraging disclosure about one's own mental health problems. Please do log into our website, itsokaytotalk.in, and you will see large numbers of such stories that young people have posted on the website in the form of essays, poems, blogs, and videos. I want to now turn to how does the work that we've been doing in India relate to the larger body of work around in other low and middle income countries. And I wanted to just draw upon 2 systematic reviews, which is a way of really collating the science from a very large number of studies to arrive at certain lessons on what we can say about the use of lay health workers or non-professional, non-specialized health workers. These are two very recent reviews published in the last year, and these brought together more than 50 studies from low and middle income countries. So this is no longer the case that this is only a peculiar example from one or two NGOs or one or two countries, but actually is now a large body of science. And much like the home-based newborn care example I gave earlier, is transforming the field of global mental health. It is in fact redefining mental health care in many different ways. First of all, it is redefining the reason why mental health care is preferred in community-based settings. It is not surprising why that is the case. It is preferred because it is much closer to one's home and therefore it is more convenient. Receiving care in the community is often less stigmatizing. And oftentimes the person who is delivering the care can also address many other social concerns and family concerns that are very closely linked with mental health. The care is delivered wherever the person finds it most convenient, most often in our own work, in the homes of the person. But also there are many other settings like schools for adolescents and also in primary healthcare centers. What comprises care, I think, is very important. Very often people think of mental health care either as pills or even psychological therapies are often seen as treatments. But I think what this large body of evidence tells us is that actually mental health care comprises a much greater deal, a much wider range of actions. It includes motivating people to seek mental health care, making people aware about the nature of mental health problems, incorporating local metaphors and language into the delivery of mental health care interventions, addressing social determinants that are so important for so many people with mental health problems, engaging family members, helping link people with serious mental illness with vocational and employment opportunities, etc. So the what is much more than just a narrow biomedical clinical approach to mental health care. The who, of course, is the most exciting. Many of you in the audience will be the who. There are many, many different kinds. In fact, in my mind, it's anyone who has an inclination, who has an interest, who has a passion, who has a motivation to provide care to others can be a mental health care provider. But across all this evidence, we see lay people, community health workers, teachers, police officers, and nurses as some examples of people who have become mental health care providers. Now, the how is important. I think it's very important to remember and recognize that these frontline workers are not working alone. They must be supported. They need to have adequate training. They need to be accredited. They need to be supported after their training. They need to be incentivized, and their motivation needs to be constantly upheld. And we need to remember that this kind of work is hard. It wears down people if they're not adequately supported. And we need to make sure that our most precious resource in the community is not worn down by the stress of this work. And we need to remember the harms and risks, and I've already spoken about one of the biggest harm, of course, is to the health worker themselves if they are not adequately supported. Another risk, of course, is that if the health worker is working alone without a linkage with the rest of the healthcare system, particularly primary healthcare, but also where needed the mental healthcare system, it is possible that an individual who needs more specialized care may simply not receive it because the community health worker is working in an isolated way. I'm now going to end by just exciting you all, I hope, with how this kind of evidence that has been generated systematically for the last 15 years by more than 100 research groups around the world now is transforming our understanding how mental health should be delivered globally. There are a number of new initiatives that are now adopting this particular approach. The Movement for Global Mental Health that many of you will be familiar with is the largest virtual network of people who have been affected by mental illness, mental health service users working in partnership with professionals. The movement has last year, actually I think earlier this year, it launched the Global Mental Health Peer Network. which is now appointing leaders of peer groups in around the world in each country. And the goal really of this peer network is to engage people with the lived experience of mental illness to become involved in providing care, in supporting others. Of course, to me, this is the most exciting development in the mental health field, because what greater expertise can you have when you want to help another person with a mental illness than having had that experience yourself? I serve on the World Health Organization's high-level commission on non-communicable diseases, and I'm really glad to tell you that mental health for the first time has been included in the agenda of NCDs, and the use of frontline workers has been explicitly recognized as a very important strategy for achieving the goals of coverage for mental health and NCD interventions. And of course, the UN Sustainable Development Goals now explicitly include mental health as one of the important targets. What I haven't included in this slide also is the World Health Organization's Comprehensive Mental Health Action Plan, which also speaks to the use of frontline workers for the delivery of mental health care. Earlier this year, I, along with my colleague Charlotte Hanlon, produced our second edition of this book. And the biggest difference from the first edition, I'm glad to say, is that the second edition is built almost entirely on evidence. The biggest section of this book, in terms of the revisions that we undertook, has been the expansion of the section on psychological treatments. And this is, of course, now built on the large body of new science that has developed, evaluated, and in some instances scaled up psychological interventions in different parts of the world. Many of the guidelines in this book, in the second edition, are in fact directly based on the manuals that were written for the frontline worker experiments or trials in Sangath and in other parts of the world. In closing, one of the most exciting things that I think this evidence is doing is also getting rich countries to reimagine their own mental health care delivery system. This is a piece that appeared a few months ago, and it's actually describing the use of lay health workers not in the global context, but in fact in the US. And I think this is a very good time for rich countries to relook at their own mental health care systems, which have become incredibly biomedical focused, diagnosis focused, medication and hospital and specialist focused. And even though these countries have 100 to 1,000 times more providers and money being spent on mental health care than countries like India, yet more than 50% of people with mental health problems do not seek or receive care. It's clear that this is not only because there are not enough mental health professionals in these countries. It's clear that there's also a need to reimagine mental health care, learning from countries like India, where community-based care by non-specialist workers is increasingly the most important delivery model for mental health care. And I think this particular piece is a fantastic example of how US-based investigators are now examining the role of lay health workers. In January this year, I had the privilege of being at a launch meeting in New York City. The lady in the middle there is Shirlane McRae, who is the First Lady of New York City, that is to say the mayor's wife, who launched the Thrive New York City initiative, which is funded by the New York City government. It is the largest citywide mental health initiative in the US. But what's really remarkable about the event where I spoke at was in the hall, there was every possible kind of provider you could imagine in mental health care, from police officers to teachers to pastors, religious leaders, to community health workers. Yes, New York City also has community health workers, and of course, mental health professionals. And the idea really behind Thrive New York City is that mental health care must be delivered across the city by a range of human providers. Really, in my mind, a very great example of a scaled up model of mental health care for all, by all. So the real lessons for global mental health is that we should now confidently move forward without any doubts in our mind that there is no scientific evidence on the safety and effectiveness of this approach, we can now confidently move forward and advocate for the scaling up of this approach of the delivery of psychosocial interventions by frontline workers, but always remembering that these workers must work as part of the healthcare system, not outside it, ideally in collaboration with primary and mental health care teams. And I've really emphasized the word in all countries, because this is an innovation that applies truly in a global sense, not just for poor people in poor countries, but for every person in all countries. In ending, I think India is really in many ways the front runner, not the only one. There are some other countries too, but I would say we are a front runner in this kind of ideological innovation transferred into science in the area of the use of community resources for healthcare. This book was one of my great inspirations when I started work in the early 1990s in the area of global mental health. Of course, there was no global mental health then. It was really just mental health in the community context. And this book, as you can see, has a very powerful title, People's Health in People's Hands. And that really has always been my inspiration, that we do need to bring people's health, and in our particular case, people's mental health, back into people's hands. It's only if we do this that will we ever achieve the goal of healthcare for all. Of course, the year 2000 is gone 18 years ago, but this year we will celebrate the 40th anniversary of this particular declaration, which is the famous Alma Ata Declaration, which not only declared healthcare for all, but really emphasized the role of communities and primary care as the foundation for universal health coverage. In October this year, leaders of the world will meet in Alma Ata again to reaffirm this commitment. And I would like to say that we now can say confidently to these leaders that we can achieve also mental health for all if we harness the resources of the community in order to do so. So thank you very much. That is the end of my talk. I hope I came across clearly and my slides were easily visible. I'll hand back now to Urvita.